In this video, I want to discuss traditional knee replacements. We want to look at how exactly conventional knee replacement worked and why it doesn't work very well in most people's anatomy. So again, to recoup, femoral shaft axis or anatomic axis, mechanical axis, two separate things, but they overlap on the tibia and they're different on the femur. And it gives you an average of 6 degrees difference on the femur. You can have a valgus deformity, a knock-knee deformity. You can have a varus deformity, a bow-legged deformity, all right? So how do we do this surgery? So typically, we start with the femur, and we put a guide rod into the femur shaft. And that guide rod is supposed to give us the anatomic axis of the femur, all right? Then we put this jig over top of the rod, and this jig is set to cut at 6 degrees. Well, what happens if someone's not at 6 degrees? Because not everyone reads the anatomy book. Some people are different. Some people might be 3 degrees or 4 degrees or 8 degrees or 10 degrees. And so when you cut everyone at 6 degrees, you're really creating a problem here. You're not going to get a patient-specific outcome, and you're going to end up with suboptimal results. It's a similar idea on the tibia. On the tibia, we put a guide rod down the tibia and make a flat cut across it. And we'll see why that doesn't make a whole lot of sense. So on the femur, once we put the guide rod in, we pin this jig, and then through those slots right there, we put a saw and we cut it, all right? It's reasonably accurate, but saws skive and move and can get kicked by hard bone, and you can be off a few degrees. The next thing we do is we put this sizer on the knee, and we determine the size of the knee. And the size, this little angel wing, what we call it, this probe right here sits on the top of the femur and tells us what size femoral component we need to use. So we need to understand rotation, all right? So when we talk about femoral rotation, at this point we've already made our distal femur cut. And now what we're doing is trying to figure out the rotation we need to put the femur in. So what we look at are these 3 lines. There's the PCA, or the posterior condylar axis. This is the medial side over here and the lateral side over here. So the medial posterior femoral condyle and the lateral posterior femoral condyle create that posterior condylar axis. Then the epicondylar axis goes between that bump over here, the medial epicondyle, and the bump over here, the lateral epicondyle. And the AP axis, or what we usually call Whiteside's line, is a line coming up the femur that lets us know the orientation of what's anterior and what's posterior. All right. So when we put this distal femur guide on there, we have 2 options, right? Option 1, we can shift the guide up anterior or down posterior, and that allows us to shift where the implant is, and that'll actually change our balance, and we'll understand that a little bit better in the ligament balancing video. But essentially, if you move it up, you increase your flexion space. You move it down, you tighten that up and reduce knee range of motion. But if it's too loose, you may need to move it down a little bit. But you're kind of guessing here. You're guessing where the patient needs to be because there's no way to really be that accurate with this. The other thing we can do is change the rotation, okay? Once we've got the position anterior-posterior figured out, we can actually use this dial to change the rotation to give us more external rotation or more internal rotation. So typically, a standard knee, we cut at 3 degrees of external rotation. So that's why 3 degrees is set in the middle. But you may want to go down to 0, you may want to go up to 6, you may want to increase it or decrease it. And this gives you the ability to do that. It's just not done very accurately. So once we've done this, you put your cutting jig on, and this allows you to make saw cuts to fit the implant. So there's 2 cuts in the front, there's 1 cut in the back, there's a chamfer cut that goes up diagonally and another one that goes back diagonally. All right. So all of this leads to a knee that's not optimal, all right? And why? Because the knee doesn't behave like this. So we talked about the kinematics of the knee in an earlier video, but this right here, this tibia, if we cut a horizontal cut like you do on a knee replacement here and just put the tibia on, you're not recreating normal kinematics. And the reason is because a normal knee, this is the lateral side and this is the medial side, has a 3-degree tilt to it. And so if you cut your tibia flat and put a flat implant on there, you're ending up with abnormal mechanics. So from the very beginning, we're already off. And if you look here, we look at the plastic piece that goes in on a standard knee replacement. This is the lateral side. We already talked about in that earlier video that the lateral tibia is actually supposed to be convex. It's supposed to hump up this way, and that allows for the lateral side of the knee, for that lateral femur, to roll back on the lateral tibial plateau. When it's concave like this, it's going to act like a lateral pivot, and that's what these knees do. All right, so you see this is a anatomic knee. All right, the medial femoral condyle comes down further than the lateral femoral condyle, and conversely, the medial tibial plateau comes down further than the lateral tibial plateau. So the medial plateau is concave, the lateral plateau is convex. Well, standard knee replacements, it's symmetric, okay? So this is designed to act more like a hinge. The medial side and the lateral side are equal. So you're not recreating normal mechanics. You're not recreating a medial pivot. And what you end up with is an implant that's not sitting where it's supposed to sit. So this is a lateral x-ray showing a normal knee here where the femur sits anterior relative to the tibia, and that means the back of the femur and the back of the tibia relatively line up. Well, on the knee replacement, this is not sitting, this is sitting how this implant is designed to sit. It's designed with the femur sitting posterior on the tibia. You've already lost the game. You cannot recreate normal kinematics when your bones are not sitting in the right orientation. So we end up with a knee that's not well balanced, where the ligament is either too tight or too loose. We start cutting ligaments to make up for this, to make it as balanced as we can, and you end up with a 20% dissatisfaction rate. And that's why conventional knee replacement has huge limitations. We're going to show you, with the design of the Journey 2 by Smith & Nephew, that specific knee, and coupling that with robotics, how we can improve patient outcomes tremendously.